So if you go ahead with the demo on the OpenMRS HIS, you can go ahead and you can check out that you are able to use all of these systems together. You should go on this link to try out the different applications. So you should try billing with Odoo. It has Senaite, it has or thanks so and Superset. So basically, if you want to have data from all of these applications into a single place, Superset will help you out with that.
So this brings us to the two examples we wanted to share with you today of deployments in production of Ozone HIS. The first one is a project in Burundi. It's in a rural hospital in Burundi. A hospital that is about like 5,000 patients a year, so not many patients, but you have like C-section, maternity, IPD, OPD, emergency room, ophthalmo, radiology, like all the services in this rural hospital. And the situation that they face is pretty simple and pretty common, is that the MOH said, okay, we want to reimburse the children and maternal care, but you need to go digital. And this hospital is a small NGO. They don't have resources for that. So they needed to find a solution with little resources, little capacity. And that's why the approach was to actually go with Ozone HIS, because it will bring them quickly the medical record, the billing, and the reporting and analytics needs that they need for the EMR. So Vineet will give more details about the system, but really quick for the context and how much effort it took to deploy this. We had a first 3-month onboarding of volunteers last August, just to onboard new people in Ozone HIS and in OpenMRS. And many thanks to them, actually. Some of them are in the room, so many thanks to them. And we set up the system. We had back and forth with the clinic to quickly set the diagnosis, set all the requirements they had. And then, after 3 months, do the training with them. So we had like continuous training, then official training when they received like certificate of the usage of the system for the different departments that Vineet will explain. And then we had a second 3 months of stabilization of the project, actually between April and June in this year, to get it ready for the launch and also for the assessment of the MOH. And yeah, that's the good news. And I bring the good news directly is that the assessment went well. The MOH was really happy with Ozone HIS. And it kind of saved the maternal and children care in the hospital, so there are no reimbursed by the MOH for those services. So that's the good news. Now, Vineet, that you a bit on the department and users.
Thank you, Michael. Yeah. So talking about UVL, as Michael shared that we had the training for the UVL volunteers in August, but and then we got another we wanted to stabilize the project. So we started in April. We got the basic requirements of getting. So the basic requirements was that they wanted a fully functional EMR, which OpenMRS is really good at. But along with that, they really wanted a billing, a billing project as well, right? So there were two options. One was to go with the billing module, and another was to go with the Ozone HIS, and then use the Odoo for that. So we went for the second option, right? So what are the advantages of that, right? So UVL EMR is currently using OpenMRS, Odoo, and it's using analytics for managing the data between these two applications, and then we are also using Open Concept Lab for the concept management, right? So when MOH Burundi came with the proposal that they want to go digital, their requirement was that they want to see, they want to reimburse some amount for child care and maternity care, right? So basically, they wanted a data regarding these things and in a single place, right? So this is where we Ozone Analytics helps us out well. So in on the Superset, we have a data of the patient in a single visit, how many lab orders did they go through, like which forms did they go through, like procedure orders, the drugs dispensed, and along with that, in the same data, they also get to know like how much payment was made for the patient. Right. Yeah. So basically, they get all of that data at a single place, which was the basic requirement. So that's why we that's where UVL we worked on UVL for 3 months. We stabilized the project. We worked on that, and it's currently being tested in the production. So when we shared this with the MOH, like they were happy to see the application, and it's going well. Yeah. So currently, talking more about UVL EMR, so we are currently handling around 300 drugs. Right, we are handling 150 procedures and 60 lab tests. Right, in the application in the project. So, sorry. So yes, so we like the synchronization between OpenMRS and Odoo, the billing, the pharmacy, the stock management. Like Odoo also helps us out with stock management. So all of those features really helps us out with getting the project ready and getting it to a stand where we don't have to do much of the work to get these things ready, like to work on these things and then test it out and everything. We know that Odoo is a pretty good application, like it handles this very well. So we just directly use Odoo, and it's working really well. Along another advantages of using Odoo. Yes, thank you. So this is basically the images. Where was I? Yeah. So other advantages of using Odoo was that Odoo also came up with price list configurations. So basically, the patients that come into the hospital or the clinic, like so they're insured patients, right? Some patients are insured at 50%, some patients are insured at 60, 70, 80, and 90. Like these are the different price ranges that the products can range for these particular insurances. So Odoo helped us out with that particular feature as well, that they have the price list functionality in that. And this is also helping out MOH in understanding how many patients of which insurance category are also visiting the facility. So this is how we are using UVL EMR. It's approved by, like it got approved by the Ministry of Health, so that's really good news. And yeah, we have it in running, and it's currently in testing. So that's all I believe is for Odoo. For UVL EMR. Anything else I might have missed?
No. Let me just tell me that we don't have much time left. So it's okay? Okay. Thank you, Vineet. And these are like the different services that are using the system. So these are the pictures where the system is used. So also wanted to mention that this project is completely available on GitHub. If you're curious about Ozone, if you're curious about such a setup, everything is available on the UVL EMR GitHub. So feel free to go check it out and ask questions if anything. All right, so let's speed up. I don't think we have questions yet.
Yeah, doesn't even have any questions.
In the chat, but let's follow up after the second case study really quick. So we had a second case of using Ozone HIS. It's simply about doctors without borders who came to us and say, hey, we would like to reduce our total cost of ownership of our digital implementations in the clinics. Because so far we've been building one implementation at a time, configuring like one clinic at a time, which is impossible. Like it's possible, but it naturally costs more and takes more efforts. So that's the second case study where we wanted to use Ozone. And I'll get into a bit more technical details about how Ozone is structured. I'm really quick about this one, and I jump into the production instance that we have. So it's the first one is an implementation in Iraq. It's a maternal hospital, and it's about like 30,000 patients a year, so 100 deliveries a week, and 200 users. So a lot of people to train. But let's jump 2 seconds into how is Ozone structured. when you configure your ozone distribution, you can have multiple levels, which means that if you are a vendor, if you are an NGO, if you are a country, then you can have one general level, one first level for everything that will be the same across your entire country or your entire organization. For example, branding, like the branding of your EMR, the branding of your Odoo, you want it to be the same across all your sites, right? Or address hierarchy for registering patients, you want it to be the same. So you can define it at that top level. Then let's say that you have province 1, province 2. You can also do that and have like province-specific configurations. And the same goes for your sites. If in one site you have HIV, the other site you have maternal care, you have nutrition, you don't want to have like all your forms and configurations and modules across the board. You want to have only what you need at your site level, because every time you do an update, it will reduce the bandwidth that you need to update your site, for example. So it's easier to maintain. And also being able to have multiple levels of configurations naturally will allow you to harmonize your configurations, but at the same time localize them. So it allows you to find a balance between localizing for your sites and harmonizing to make your life easier to maintain those distributions.
For example, if you talk on a country level, so on the country level, you can define how the identifiers of the patients will be for the whole country. So basically, if a country has their own identification, so they can define it at the country level, and then all of those can be used on the province as well as the site level as well.
Yep. And in a nutshell, that's how MSF is now able to reduce the total cost of their implementations, because now they have the hierarchy, they have the structure to reuse what is used in each implementation. So if tomorrow they have another maternal hospital to open, they know they can reuse that. But maybe this hospital has mental health as well. Boom, they can choose the configuration. And I quickly switch to the next slide. Here where we had examples of the different levels. Like I said, branding is top level, address hierarchy, and then maybe the province you have some specific roles, some specific patient attributes, and then down below you have what is really clinical related and program related content that you want to see, or maybe specific modules. All right, so that was about the 2 use cases we wanted to share with you today. Next slide. I'm sorry, I didn't go full screen. There you go. So, maybe you're curious about this, or you want to learn more, or you have questions. Well, reach out to us, grab us during the conference, or feel free to engage in the community channels. One is every Wednesday there is a call at 5 p.m. EAT. So feel free to jump on that call to ask any questions. Can be technical, can be implementation. There's also a Slack channel on OpenMRS Slack, so Ozone is the right one. And then if you're curious about those case studies we just presented, they are also available on the Ozone HIS community website. And that's it.
Yeah, thank you. We would also love to hear from you, like what's your feedback and what's your opinions on the project, and how we can, what the issue that you issues are the situation that you have in your implementations, how we can sit together and solve that out. So yeah, we are open to feedback and discussions. Thank you, everyone.
All right, so we actually have 3 questions from the form. First one is from Dennis, so thank you, Dennis, for that. And the question is about, are there any misconceptions you've needed to debunk regularly about implementation or stakeholders considering Ozone and OpenMRS HIS, but are on the fence? Not really. It's been... I didn't get the question. Okay. No, actually, it was more enthusiasm, and of course, like you've seen, it's a lot of, there are some technicalities to understand on how you can reuse things, But that is not important for the users or the implementers themselves. Like, as long as they know that they can do it, that's the main thing. And what we have to explain is more how to kind of play and contribute with the community. Because, okay, we had two principles to reduce the total cost of ownership. Like I said, there is this technicality of Ozone. But the first principle that we insist a lot when someone is asking, oh, I want to implement is about, okay, we'll try to follow as much as possible the community-driven development, meaning we don't want to fall. And we want to reuse things as much as possible. So contribute with the community to features, modules, and reuse them with the community. But will also allow you to do the same in your implementation. So I'd say that what has been important is really to explain how the community works. So for example, the OpenMRS community, and how you can put it in place practically in your site. So this analysis of, okay, what do you need in site 1, 2, 3? What do you need at your province level? And what do you need at your national level? Has been what takes a bit of time for dividing things. The good news is that if you decide to do something in site 1, and after you realize that it's actually for the national level, you can move things around. So it's quite flexible as well.
So that flexibility makes users like confident in the system. And there's also an option, like a future possibility that if they want to expand into other systems, yes, that's possible with Ozone.
All right, so we have a next question, which is from, this screen is too small. Jean Shimas from PIH. And the question is about, can you let us know the use of ERP Next in Ozone? Right now, Odoo is the default one in the system, and that's the one we have internally most experience with. But you should be able to plug ERP Next in Ozone. What is important to understand, like the things that are recurrent when you add a software in the system, most of the time is about your system will use Docker most of the time. So you can easily plug the application in an existing Docker or tweak a Docker file to run your additional application. Then the second thing most likely is about authentication. How will you authenticate in this ERP Next, for example? And then the third thing, most likely, is also data exchange. And in Ozone, it's using Kafka routes to exchange data between the systems. But you can go with another system. If you prefer to use something like OpenFN for your data exchange, you can go with whatever interoperability layer you want in your Ozone distribution as well. So you also have that flexibility. We have also a third question, also from the PIH team, so thank you so much for that. And do you have PACS feature in Ozone? So radiology and imaging system in Ozone. So there are today two different integration of PACS in Ozone, but the two right now are with ORTank, so which is an open source software as well for radiology. And that will simply allow you, when you're on OpenMRS in your patient file, to have a link to the PAC viewer. And so you can click, and it will automatically bring you to your PACS and ORTank. So that's the kind of integration that exists today in the Ozone ecosystem for radiology.
So images taken in the ORTank are actually saved on the OpenMRS side as attachments. So that kind of integration feels seamless.
All right, well, thank you so much. I wasn't expecting so many questions. So we have a fourth one from Jude from Science and IT. Thank you so much. And the question is about how does the local specific requirement customization are handled? Can existing OpenMRS implementation be integrated with Ozone? Short answer, yes, yes. So, like I said, the requirements here. If you have site-specific, you can really, and I will go back to this concrete example. Let's say you have specific modules or you have specific forms in one site only. You can define them in the site level. So let's say it's site 33. you can define them at that level. You see right now in the example, we have the modules at the national level, but maybe you don't need all the modules at the national level, so you want to define them at the local level. And what is important also, the way the hierarchy works, you can customize that. It's a Maven, Java Maven scaffolding, so you can customize those rules. And also the logic that we implemented, at least in all implementations to make it easy, is the lower side, the lower level will always override the above level. So this way, even if you have something defined at the above level, the side is the primary because you want to have things localized for your clinic. And then the second question from Jude was about, can existing OpenMRS implementation be integrated with Ozone? The answer is yes, in the sense that maybe you already have OpenMRS, but you want to integrate multiple things. So you can do that move, you can add things. And if you have an existing distro file, like if you have an existing OpenMRS implementation, we have some documentation on how to transition between that setup and the Ozone setup. So happy to share also that documentation. And we have about 4 minutes left. One question from Arthur from Soldevelo. What were the challenges you spotted during the implementation in Burundi? And how did you manage to build awareness? To build the awareness on the hospital side that they need to stick with the system as is rather than customizing it.
Yeah, sure. Thank you. So since Ozone is currently in a development stage, like we have like the releases are currently alpha. So yes, we did face some issues. There were some some issues that we found during our implementation. But yes, we were proactive about sharing that with the Ozone team, and yes, they were really helpful with all the discussions and everything. So if I talk about in specific, so basically there are some files that Ozone comes but which gets overridden by the implementation files that you have on your end. So when you migrate to Ozone, it might override some files on the Ozone end. So you should look out for that particular thing. And I'm currently talking on the development level. So one was this. So yeah. And
the second part was about how is the hospital side, how do they accept to not customize the system and use it as is. And that one is really about to explain them what are they using. Like we said earlier, the clinicians and the users, they don't want to know about the technology, otherwise they will be distracted from their work and the patients. But still, it is good to involve them, as we all know here, in the process as much as possible, and explain what is OpenMRS, how does it work. And so, when we present a feature, when we present one of the services, we always show them what is by default in the system. And we don't open the door too much about like, oh, you can change this, you can change that. Of course, we want to accommodate as much as possible to what they need, but we want them to put skin in the game when it comes to customizing it. Otherwise, like, they will ask everything, as we know. So we are really challenging the fact that they will need something else. Like we are here a community representing like many countries, many sites, and I'm sure in OpenMRS, it's well reflected that we try to make a system that can accommodate many types of sites. If there is a change still to be done, change request or new feature to be built, then again, we will involve them in this requirement capture and design, and also explain them. It can take weeks and months, and practically the way we do it, probably like others here, is we will develop the feature as a release candidate feature, really test it with the sets of users, and if it makes sense also with the community and other implementers, see what is the path to bring it back to the community. But as soon as possible, because a mistake that we did in the past was to develop features and modules, and then after like months and sometimes years, trying to figure out how we can bring it back to the community. That was that backfired, of course. Like in terms of cost, if we need to manage different products, the more we waste, the more we pay. So And for the clinic, it's important to understand that as well, because on their maintenance cost on a monthly or yearly basis, this also for the clinic will reduce the cost. If we have this implementation in Burundi and we need like one dev, two devs, and many, many people to maintain the system, it doesn't make sense. So really encouraging them to use what exists is also a guarantee that they can reduce the cost of their digital implementation. Because here we are not talking about MOH implementations on national level, but more NGO side. So yeah, it's okay like this. And I think that's it to all. 50, good. Thanks everyone. I don't know if there's one last question. You good? If you have questions, yeah, you have one? If you have questions, feel free to grab us anytime.
Sorry, I didn't get the memo about the question. But one of my questions has been answered, and it was about your existing the existing workflows that you worked with, and how you are migrating the Ozone to work with the existing workflows, and the challenges that you faced. But I think you answered it partly. So my only question now is about hybrid model of local storage versus cloud, and if you are doing any of them. Thank you.
You're welcome. So the question is about, like we had, the discussion we had earlier on, so cloud hosting versus on-premises hosting. Those two case studies, so the MSF one is on-premises, and we rely completely on premises, but we have redundancy on premises between sites and geography in case of disaster. So that's how we ensure redundancy, and there is no synchronization of data in a single place, except for VHIS2. So we use actually OpenFN, I didn't mention that, but in the MSF use case, we use OpenFN for syncing data automatically between the EMR and the VHIS2 tracker. So people don't need to, like go through those endless forms and manually enter the data in the VHIS2. OpenFN is doing that job of syncing automatically all those insured data. But yeah, it's redundancy on premises. And for the Bondy project, that is a cloud project, but we are looking into options and happy to, if anyone has idea, to see how we can have redundancy between the local and the cloud. That's something that we didn't crack yet, so we are still looking for solutions. Like we mentioned Kubernetes earlier on, so we've been looking into Kubernetes setup as well on the edge, Kubernetes on the edge, to see how we can have this redundancy between the two. Yes. And that's it. So thanks everyone.
Thank you everyone, and a shout out to Mekong for working on the project.
Yeah, I think it's good to also mention that. So Mekong, and sadly we don't have Dimitri, Romain, and the team with us today, but Mekong initiated this project a couple of years ago, so important to give them the credit. So here we're just trying our best to represent their work, but yeah, credits to Mekong team for that. Thanks everyone.
Thank you everyone.